Happy holidays, everyone. I hope that you are having a good start to the holiday season. Today, I'm joined by Dr. Heredia. By the way, I'm Diane Cohen with MacroPro. Doctor, how are you doing?
I'm doing well. Thank you for asking. How are you?
I'm fantastic. You know, the other day when we were talking, I found out how you got the name of your business. Maybe you can share that with everybody because I just think Good Mood Medical Legal is such a great name.
Yeah, well, good mood. Everybody wants to be in a good mood, hopefully, especially around the holidays. The story is my son is a baseball player, and about 3 years ago, we were trying to decide on this company name, and we were on a long drive and going through brainstorming with him at 15 years old at the time, and we landed on Good Mood Legal. It's a play off of med legal, but also good mood because we're in the field of psychology and this is life. Good moods.
I think that's great. I think it's wonderful. And the information you share with our attendees is always so great. I'm going to do a little bit of housekeeping and then we'll go ahead and turn this over to you, Doctor. So just as a reminder, everybody, this webinar is worth 1 CEU, California CEU. It will be emailed over to you within 1 hour, your certificate that is. If you have any questions of Doctor, please put them in the chat box and we will ask those questions of Doctor as we can. And in addition to that, if you'd like to see this program again, we'll be able to do so on the MacroPro YouTube channel. Now, Doctor has lots of information, so please make sure that you download the PowerPoint that he's got today. He's also got some really cool technology he's going to be using. So, Doctor, tell us about that.
Yeah, so you'll see my first slide come up in just a few moments, and you'll have an opportunity to scan a QR code. You have your phone or your tablet ready to scan the QR code, and it'll take you to a few questions that I have that'll pop up throughout the PowerPoint slides, and it'll allow you to participate and engage with the questions and the PowerPoint as we discuss deconstructing psych reports.
I love that because we get to see it in real live up to the second, right? I mean, it happens really quickly and we get to see that. All right, Doctor, I'm going to turn this over to you.
Thank you, and thanks for having me. Thanks for everyone attending today. I'm Dr. Heredia. I'll introduce myself a bit further and give you some of my background, and I'll start the slides here without further ado. I'm really excited to provide some information about psych reports, and particularly deconstructing them is what I call. We'll go through and discuss what should be in psych reports when you get them, what you can find for yourself, what should not be in those reports that I often see in psych reports, unfortunately, and I'll give you a play-by-play on exactly how to go through a psych report and pick the information that's needed so that you can get a full grasp and understanding of what the doctor is saying, and also if there's any problems that can be identified. QR code, as we go through these slides, there'll be some questions that populate and your responses if you would like to participate, and I do encourage participation. So please just type in or select the options as we get to those questions, and your responses will populate on the screen for everyone to see. There aren't any names associated, so this will be entirely anonymously. It just kind of gives us an idea of the community and those folks on the call and how their responses apply to psych reports. Some goals for today in this session. Again, I'll introduce myself in just a few moments a little bit further. I'll also discuss the 5 parts of a psych report. Every psych report should have 5 parts to it, so we'll go through all 5 parts in deconstructing psych reports. Along the way, I will identify some common flaws that are found in psych reports in each section. And we'll go through those 5 sections of the psych report and how those sections should support the doctor's diagnosis. DX is the abbreviation for diagnosis. And along the way, we'll also discuss the importance of substantial medical evidence and how this all applies to compensability. So I'm Dr. Heredia, and I wear several hats. One hat is educating folks like yourself and providing these training sessions, which I absolutely enjoy doing, and for MacroPro and friends, also for law firms and for insurance companies when there is a need. and to provide those CE units. I'm also a psychology professor. I teach at the college level a variety of psychology courses. And one parallel that I find in my work providing trainings like this one today, and also the lectures and discussions that I have with my students at the college, is psychological testing. And psychological testing is definitely a part of every psych report in work comp. So we'll go through psych testing today. Usually my students know nothing about psych testing and have lots of questions. And of course today, as I mentioned, we'll discuss psych testing and hopefully answer some questions that you might have. And I am the director and founder of Good Mood Legal. Good Mood Legal is a psychology practice where we have 5 psychologists on our team who do QME work, AME work, fitness for duty evaluations, and things of that nature. All of their information is on our website if you're ever interested in who those psych doctors are. That might pop up on your panels. And what I do with Good Mood Legal is mostly review psych reports written by other QME and AME doctors or treating doctors. Usually they will submit a report to folks like yourself, and if it's highly problematic or maybe a high exposure case, insurance professionals, risk professionals, defense attorneys will reach out to me and say, I have this psych report, please help. And what I do is I really just go through and I deconstruct that psych report. I find all of the major flaws and write it up in easy to understand terms with usually a script of questions for the attorney to go depose the doctor with. So I'm excited to share some of that information and how I identify problem areas in deconstructing psych reports with you today and give you insight about how you might be able to do this for yourself. Again, if you do have any questions, please go ahead and pop them in the chat, and I'm happy to answer any and all questions. Even after today, if something pops up, you can feel free to reach out to me at the office or email, and I'm happy to discuss. So here's our first question, actually. Hopefully you were able to scan the QR code. If not, it's in the top screen there, and you can participate with answering the question here on the screen. What are the reasons being identified as the cause of psych claims you are seeing? I'll give you a moment to plug in some responses there. See if I can do it as well. There you go. Thank you all for participating. What are the reasons being identified as the cause of psych claims that you all are seeing in the psych cases or the psych claims that you are handling in your line of work? So there, I just also participated. Great, so we see stress is really large and bold in the middle. We also have anxiety, depression, the work environment as the major issues. And when the font gets large and boldface, that means multiple people on the call are answering in that manner. So thank you. Again, thank you for participating. So it gives us an idea that stress, anxiety, PTSD, harassment, workplace environment, those are all major issues contributing to psych claims in our industry. I'll go ahead and move on to just keeping stress, anxiety, PTSD, hostile work environment at the forefront as I go through the next slides. I'm sharing a figure, that I created called the Psych Diagnosis Vulnerability Model. Psych Diagnosis, that's the first piece, right? And in the middle in the circle, you see Psych Diagnosis in blue. That is resting on top of a triangle that I call the report. And attached like balloons to the psych diagnosis are causation, GAF, disability, apportionment, treatment. And I say balloons because just like balloons, those 5 areas are very vulnerable in the psych report. Those are vulnerable areas of the psych report. They rest entirely on the doctor's diagnosis. Stated a different way, if the psych doctor's diagnosis goes away or is successfully challenged, it'll roll. Imagine that psych diagnosis rolling off of the report and floating away, right? That means it's going to take the causation, gap, disability, apportionment, and treatment with it. They will fall by the wayside. We will never have to worry about causation, gap, disability, apportionment, or treatment if there's no psych diagnosis. And that's because of the labor code that we are all governed by, Labor Code Section 3208.3. That says there must be a psychological diagnosis supported by substantial medical evidence in order for there to be a compensable psychiatric injury, right? So it's really that report that the psych diagnosis rests on that we are going to look at today, and we're going to deconstruct the report in a way to really find and look for the doctor's substantial medical evidence in the report to see if it supports the psychological diagnosis. And if it doesn't, then what, right? We'll answer that question as we go through the slides. Just want to give you a visual of what's going to guide our discussion today. So I mentioned substantial medical evidence a few times, right? And the psychological disorder labor code, or psychiatric injury labor code 3208.3. This section of the code says has a lot of verbose language. I'm going to give you two key takeaways from this section of the labor code. One is what I've already mentioned. There must be a psychological disorder in order for there to be a psychiatric injury, and the psychological disorder must be supported by substantial medical evidence in the report, right? So that's one. Two, key takeaway is that the psychological disorder must come from the DSM. Now, for those of you who are new to the DSM abbreviation, DSM stands for Diagnostic and Statistical Manual of Mental Disorders. I put on the screen here for you all to see DSM-4-TR, DSM-5, and DSM-5-TR. These are three versions of the DSM that are being used by psych doctors currently, today in 2024, and will likely still be used in 2025. But these are all three versions of the DSM that we have to consider because they're different versions of the manual. Now, every psychological disorder lives in the DSM. It's considered, the DSM is considered the Bible of psychology around the world, right? It's published by the American Psychiatric Association. It's about 900 pages. Nobody wants to read all 900 pages, but psych doctors should, so that they know what they're doing in their line of work. And the DSM versions are important because, well, for a lot of reasons. One, every psychological disorder lives in that manual. If the psychological disorder is not in the manual, that means it's not real. It's not a real disorder. Number two, the GAF, Global Assessment of Functioning, lives in the DSM-4-TR, but was eliminated from the DSM-5. The 5 axes diagnostic system, if you've ever read a psych report, you probably do the same thing I do. You flip to the back of the report first and foremost. That's what I do. I try to find where is that page that the doctor gives the diagnoses, and what diagnoses did they give, right? Well, usually you see the diagnoses on axis 1, axis 2, axis 3, all the way to 5. The DSM-5 eliminated the 5 axes diagnosis. We have to consider all these things, and then I'll give you one more piece of information about these different versions of the DSM. For those of you who deal with PTSD presumption cases, the labor code 31215, I believe is what the labor code is. It's popping in my head for presumption, states that the doctor must use the current version of the DSM. Anybody know what the current version of the DSM is? It's the DSM-5-TR, published in March 2022. That is the most current version. Doesn't have a GAF scale, was eliminated. Doesn't have 5 axes diagnostic system, that was eliminated. So one might ask, how can the doctor use that current version of the DSM, but also be required to give a GAF score if there's no GAF in that manual? I also asked that question. I'm perplexed. I don't know why the legislature did that, but they did. So we have to deal with it and look at that in deconstructing psych reports. Now, all along, no matter what version of the DSM the doctor used, the doctor must provide substantial medical evidence in their report for the diagnosis they give. Substantial medical evidence, another word for that is support. They have to support the diagnosis they gave. So we're going to look at the support or the substantial medical evidence in deconstructing psych reports in the next coming slides. Another figure for you. You might recognize this triangle with the circle on top, right? So the 5 sections of a psych report. There are 5 sections of every psych report. Sometimes the doctors call them different names, but these are the 5 sections the doctors must include. The 5 sections are the patient's life history and presenting complaints or symptoms, the doctor's report of their mental status examination, the psychological testing data, the review and discussion of the patient's medical records, and lastly, number 5, collateral sources of information. I'll go through each of these 5 sections in deconstructing psych reports as the slides continue. But remember, as we go through these 5 sections of the psych report, we're going to look for one thing, and that is substantial medical evidence. Where did the doctor put substantial medical evidence in these 5 areas that would support their psychological diagnosis that you find towards the back of the report, right? So that brings me to the next question. Get ready. There's another question coming up, if I can get there. Oh, before we get to the question, right? The point is, right, we want to go through these 5 sections and identify the substantial medical evidence. I have worked in this area in psychology work comp for 24 years, since the year 2000, and all along reviewing psych reports from other psych doctors. I rarely, very rare occasion, will find a psych report that I read from another psych doctor that constitutes substantial medical evidence. Stating that a different way, I rarely find information in these 5 sections of the psych report to support the doctor's diagnosis. And so, like I mentioned at the beginning of today's talk, what I do in my line of work is I help attorneys and adjusters and risk professionals identify where the doctor went wrong, and also write a script of questions for the attorneys to go depose the doctor. The goal is pick apart these 5 areas in a deposition, get it on the record where the doctor doesn't have the support for their diagnosis, and then just like the diagnosis went away, it faded, right? All we are left with is a psych report. There's no diagnosis that's supported. So then what? GAF, apportionment, treatment, disability, causation, they all go away. There's no compensable psych report, or psych injury, I should say. So I think that would be the goal, to determine, right, if the doctor's report supports their diagnostic conclusions. So it brings us to our next question. Again, here's the QR code for you to scan and participate if you haven't already. The question is, which psychological diagnosis do you see most often diagnosed by psych doctors? So when you're reading these reports, they're sent to you by the psych QMEs or AMEs or treating doctors. What are the diagnoses you see most often given by the doctor? Oh, and this slide gives us some percentages, which is nice. We're equal. Anxiety and adjustment. Anxiety and adjustment. It's interesting. I am here on the screen. You can probably see me. I cannot see you. And I don't know which companies you all work for or what line of work you're in, what your job titles are. But it's quite interesting to me because in 24 years reading psych reports written by other psych doctors, I see something not very different, but quite different. I see major depressive disorder diagnosed most often in 24 years. That's okay that you don't see that. Let's go with generalized anxiety disorder and adjustment disorder. Oftentimes, the adjustment disorder, when given by a psych doctor, it has modifiers or specifiers at the end, attached to the end of that diagnosis. So the doctor will either diagnose an adjustment disorder with depressed mood and mixed anxiety, or the doctor will diagnose an adjustment disorder with mixed anxiety, right? And then generalized anxiety disorder, that's just like it sounds. That is an anxiety disorder that has specific requirements the person must meet in order to really have that diagnosis supported. Then we round out with PTSD and an anxiety disorder not otherwise specified. Great, thank you so much for participating. So we'll keep these disorders in mind as we speak, or as I speak in the next coming slides. And I'm going to go through now all 5 areas. What happened? Oh, the 5 areas of a psych report. So the first area of the psych report is the patient's life history and their presenting complaints or symptoms. Every report must have a complete history of the patient's symptoms or complaints. When I read psych reports over 24 years, I find that section of the report, and I usually find a heading on the report that says something like current complaints, chief complaints, or patient's life history and complaints, something like that, right? And what I do is I take my yellow highlighter, you could do the same thing, and I highlight the 1 or 2 word phrases that are actually truly a symptom or complaint that the doctor says the patient told them on the day of the exam. And what I find with my yellow highlighter, I then type it into a Word document. This is just for myself, right? The Word document I call the list of the patient's complaints. And usually what I end up with, 25 years, it's really, really the same. Every report is quite similar. No one report is the exact same, but they're all quite similar. And I end up with a list that sounds like this: depressed, anxious, sad, pain, sleep problems, concentration difficulty. That's it. Give or take a few symptoms, I always end up with very similar list of highlighting that the doctors say the patients complain about. Depressed, anxious, sad, pain, sleep problems, concentration difficulty. And that's exactly how I'm reading in the reports the doctors state these symptoms or complaints. The big problem in this section of the report is the doctors do not provide a complete, that's the key word, complete history of symptoms or complaints. So what does a complete history sound like, right? Let's deconstruct this section of the psych report. A complete history is where the doctor provides information about the frequency, intensity, duration, onset, and course over time of each symptom or complaint. Symptoms, complaints, those are synonyms, right? So I have on the screen here the acronym FIDOC. FIDOC stands for frequency, intensity, duration, onset, course over time. It would be very simple for the doctor in an exam room with the patient face to face to take a complete history of their symptoms or complaints. Now, even if the doctor is allowed to do a telehealth appointment, which I really don't recommend in psychology or psychiatry, there's so many pitfalls and things that could go wrong with telehealth in this specialty. So I don't recommend that you all allow the doctor to do that. And remember, the labor code says doctors cannot do a telehealth appointment unless they have agreement by both parties. So you can opt to not allow that to happen, and that's my recommendation to you all. I have an entire talk or presentation on telehealth psychology and psychiatry appointments. So if you're interested in learning more about that from me, you can contact me later. I'm happy to discuss or share. Nonetheless, however the exam takes place, the doctor could very easily collect information about the frequency of a symptom by saying, hey, Ms. or Mr. Smith, you said you have anxiety. That's your symptom or complaint. Can you tell me about the frequency of your anxiety? Or how often are you anxious? And then the patient might tell the doctor back, anxious every day. Or the patient could say, I'm anxious about 4 or 5 days out of a month. That's a huge difference. We can never assume just because the doctors list anxiety that is all the time every day. So the doctors need to ask this information and then put it in their report for all of us to read. I is for intensity. The doctors can also say, patient, you said you're anxious and you told me you're anxious every day. How would you describe the intensity of your anxiety when you experience that symptom? On a scale of 1 to 10, with 10 be the absolute worst imaginable, like you have to go to the emergency room? And the person might say, oh, I would describe it as, let's say, a 4. Or they might say it's an 11. Whatever the number is, whatever the intensity rating is, we need to know and we need to be able to read it in their report. And I rarely see that, unfortunately, in psych doctors' reports. D is for duration. You said you're anxious. When you have your anxiety, how long does it last? The person might tell the doctor, oh, it lasts 24 hours. Or the person might tell the doctor, oh, it lasts for about 30 minutes in the morning when I wake up. Well, I had to do a presentation. If this was live presentation, I would be even more anxious than I am now. There's a little bit of anxiety that sets in, right? When you have to be on the stage or a platform. So because I had an anxiety moment for a couple minutes in the morning when I was getting ready for this, does that mean that I have a generalized anxiety disorder? Absolutely not. There must be a threshold, right? And a little anxiety for a human being is actually normal. So if it's not normal, reasonable, or expected, then it could possibly be a psychological problem. But normal, reasonable, expected symptoms or complaints, that is what we call human nature, not a psychological injury or a psychiatric injury. O is for onset. Patient, you said you're anxious. You said you're anxious every day and it lasts for several hours. When did it first start? When do you first remember having that feeling of anxiousness that you experienced? They might tell the doctor, oh, about 4 days after the work injury. They might tell the doctor, I've been anxious since I was a teenager. Or they might tell the doctor, oh, the very first time I had anxiety was about 3 months ago. After I had a car accident and I've never been the same. If the doctor doesn't ask these questions in their exam and then put the information into the report, we will never know and we cannot speculate. So the doctors must put this information in their report. Lastly, C is for course over time. Patient, you said you're anxious and you said it started 3 years ago. In those 3 years, has your anxiety gotten worse? Has it gradually gotten better? Did it go away and then come back at a certain point? What is the course your anxiety has taken over time? We also need to know that information, especially for apportionment, causation, etc. We need to know FIDOC information in order to have a complete history of the patient's symptoms or complaints. Unfortunately, you will rarely find a psych report that has a complete history of the patient's complaints or symptoms. And if that is in fact the case, the doctors did not provide a complete history, that's a substantial flaw in their report. We also need to look in this doctor's report in this section and determine, did the doctor conduct the evaluation or did they conduct it with participation and help from people in their office or outside sources, right? Because that's a no-no. According to Labor Code 4628, the physician who signs the report must write the report, do the evaluation, and come up with all the conclusions and interpretation of testing scores. Oftentimes I see in the little small fine print above the doctor's signature that a Ms. Jones helped me with the testing and the review of records and or taking the patient's history. That's a no-no. Who's Ms. Jones? And are they the physician or the chosen QME? Probably not. So we have to look for that information. We also need to look for, did the doctor charge and get paid as a QME for all of the requirements of testing and record review and taking the history of the patient, but have somebody else do it? And then they charge the QME rate, because that would be a major violation of the labor code. There are more what I call methodological concerns, how the methodology that the doctor uses to do their evaluation, to write their report, concerns that just throw up red flags that you would want to challenge or question the doctor on, because it's quite likely that the trier of fact, the judge, or attorneys involved would be able to have the understanding that this report does not constitute substantial medical evidence and is in violation if any of these methodological concerns are valid. Another methodological concern that I see so often is that the doctor does telehealth, like I mentioned a few moments ago. They do a telehealth exam and they say that the person completed a battery of psychological tests, even one of those tests being the MMPI. Now that makes me question, how in the world did the patient complete a whole battery of psychological tests if they were at home? Makes me wonder, and this is my cynical self saying, did they sit around the dining room table and answer the questions, bubbling them in together with their family, potentially laughing and having fun with it? Because that's not a true assessment of the patient, right? And their symptoms or complaints or their credibility. So we have to know this information, and we have to go through this section of the report with a fine-tooth comb and be really nitpicky to determine that the doctor did it appropriately and completely. I'm going to move on to section number 2. Oh, I'm sorry, we're not going to section number 2 yet. More of the history. So history continued. Not only does the doctor need to provide FIDOC information about every symptom or complaint, the doctor also needs to provide a familial history, education history, a military history, marital and relationships, social, occupational, medical, and psychological or psychiatric history of the patient. So they have to ask all of these questions. They have to spend the time with the patient and go through and get this information in order to be able to arrive at some valid, reasonable conclusions about the patient's psychological condition and the cause of it, right? So we need to know that the doctor took this information. And unfortunately, in the psych reports that I read, a lot of this information on the screen here is ignored or missing from their report. And they should be questioned, the doctor should be questioned about this if this is in fact the case with the doctor's report. Sleep problems. I mentioned to you that I see sleep problems or complaints of sleep issues in almost every report that I read in 24 years. Okay, fine, I get it. Human beings have issues with sleep. Does it mean that their sleep problem is potentially causing or supporting the psychological disorder the doctor gave? Now that's where I pause and I hesitate to answer yes or no, but I want to read more in the doctor's report to really see if the doctor makes the case for sleep problems contributing to the psychological disorder or emotional issues. And what I find is appalling, to say the least. The doctors never, I should say never, almost never provide a complete history of the patient's sleep problems. What would a complete history look like? First of all, we need to know, what are the sleep problems? Oftentimes the doctor just says sleep difficulty. What does that mean? Did the person have trouble falling asleep initially? Is their problem that they wake up periodically in the middle of the night? Is their problem that they wake up in the middle of the night and then they can't go back to sleep for a long time? Or is their problem that they have nightmares during sleep? Or is their problem that they wake up too early in the morning for their liking and then they can't go back to sleep? Is it a combination of any of those? We have to know the information. Next, we need to know, did the person have these sleep difficulties before the work injury? Is it a part of their normal sleep pattern for their life? Doctors don't discuss that, unfortunately. And then it almost seems that the doctors in their reports, they want the reader of the report to believe that any sleep problem is because of work. And that's unfortunately rarely the case. Human beings do have sleep problems. Some people have sleep apnea. Sleep apnea will cause problems, make you wake up in the middle of the night, breathing issues, nightmares, snoring, which leads to other internal problems. So we need to know the information. FIDOC and middle of the night, early morning, not going back to sleep, prior to work, following the work injury. We need to know all of it, and I rarely find that in the psych report. So when we don't find this information in the psych report, the doctor should be questioned about it. The details matter, as you can tell, right? Going through all of this information, I know it's a lot, but the details matter. Events of employment immediately following the reported injury, right? Somebody's injured at work. What happened right after that? Did they stop working? Did they keep working? Did they have problems working? We need to know. Medical treatment, both received by and offered to the applicant following the reported work injury. We need to know what happened, by who, where, why, when. We need to know all of that information. Information naming the provider, the dates of any treatment, specialty, the location, the medications prescribed, the dosage, all of it. It's so important to have a full understanding of whether or not the applicant is truly suffering from the psychological disorder the doctor gave, and also getting the appropriate treatment if that is the case, right? Or if they're not suffering from that psychological disorder, maybe the doctor got it wrong. The doctor diagnosed an incorrect disorder, or the doctor didn't have enough information but gave a psychological diagnosis anyway. They would never do that. Unfortunately, yes, they would. I see it happen all the time, and we have to deconstruct these psych reports in order to determine what's really happening with the report and the doctor's conclusions. Now, moving on to number 2. This is the second section of the doctor's report. Remember, there are 5, right? Second section of the doctor's report is called the mental status examination. You'll often find this section with a heading in the report. It's called mental status examination, mental status exam, mental status evaluation, maybe they call it. Nonetheless, a mental status examination is about a 15 to 30-minute portion of the doctor's face-to-face time with the applicant. This 15 to 30 minutes is reserved only for the doctor's observations of the patient. So they should be observing with their eyes and their ears and their senses the patient's behaviors in front of them, right? So it's no more, tell me what bothers you, what are your complaints, what's the frequency, more of that. 15 to 30 minutes where the doctor's just observing the patient in the areas of mood, memory, concentration, insight, and judgment. On the middle of the screen there, I put the mood, memory, concentration, insight, and judgment. Why? Why are these areas important? Because the psychological professional literature says that when a person has significant abnormalities in mood, memory, concentration, insight, and judgment, at least most of those areas, significant abnormalities in most of those areas, it's likely that that person has psychological problems. So that would be support for the doctor's diagnosis. And that's why the doctors have to assess these functions, these cognitive functions, with observations, right? So when I read a psych report, what I read sounds like this. I'll turn to the section and I try to read through, and the doctors say something like, to the effect of, The patient presented with an anxious and depressed mood. Their affect was constricted. They had intact memory. The concentration was fair. Insight and judgment were restricted. That's it. I highlight with my yellow highlighter, anxious, constricted, intact memory, fair concentration, restricted insight and judgment. And those yellow highlighted phrases, those aren't observations. Those are what I call the doctor's summary conclusions. What we need in this section of the report and what is supposed to be there are the description of the doctor's observations that led them to make those summary conclusions, right? So what did the doctor observe that led them to state the person presented as anxious? What did they observe? The doctors could observe shaking leg, disheveled appearance, avoidance of eye contact, crying or tearfulness, wringing their hands. They could observe so many things. And I just rarely see any description that indicates the doctor observed or supported their summary conclusions, right? So where's the observational data? When you read that section of the psych report, that's what needs to be at the forefront of your mind and your approach to reading mental status exam reporting. Where's the observational data? Did the doctor only present their summary conclusions? So if it's missing observational data and they only presented summary conclusions, huge problems. The doctor should be questioned about that. Now, I often find inconsistent information in this section of the report as well. And this is what I mean by inconsistent information. In section number 1, I often see the doctor say, the patient complained of difficulty with concentration. Fine, that's what the patient told the doctor, right? Now I get to section number 2, mental status exam, and the doctor says concentration was fair. That's an inconsistency. They said they have difficulties with concentration, but when the doctor is observing the person, they're saying their concentration's fair. But then when you get to the end of their report, they diagnose a generalized anxiety disorder, and they don't say anything about the person's complaint of concentration, but the doctor not observing any problems with concentration. That's a big problem. The doctor should be questioned about that. In this section of the report, I often see as well, the doctor will say, the patient presented as anxious. They told me that they're fearful, that they have worries, that they can't drive without having a panic, some sort of panic and fearfulness. Those are complaints, right? Oh, I'm fearful. They told me that they have panic, that they worry. Those are complaints. And the complaints should never appear in the mental status exam section, because this section is reserved only for the doctor's observations of the patient. So that would be also a substantial flaw in the doctor's reporting. I'm going to move on to the next section, section number 3. But before we get to that section, there's another question for us to participate with. I think you've all participated, or a lot of you have already. Thank you for that. Psychological test. Which ones do you see discussed in psych reports? What are the psychological tests that you see discussed in the reports that you're reading? Thank you. So it looks like we have Beck Depression Inventory, the MMPI, and the Epworth as our big 3. Let's scroll down to see more. Okay, yeah. I see those very often in psych reports as well. The Beck Depression Inventory, the Beck Anxiety Inventory, those are usually given together by psych doctors. the Epworth Sleepiness Scale for sure, and then the MMPI. So again, thank you for participating with that. We'll go with those tests in discussing section number 3, psychological testing data. Every psych report must have psychological testing section, meaning the doctors need to give psychological tests to the patient during the exam. They also need to report the results of those tests in their documentation or their report. The big problems that I usually see in this section are the doctors don't give any tests at all. That's a big no-no. Or the doctors give tests and then they don't put in the scores for the MMPI or the MCMI. They just say, oh, the MMPI said this about the patient, but they don't give us the scores. The scores are needed in the report. And if you ever find a report that don't have the scores in it, the numbers that the person earned on their performance on the test, I would recommend that you reach out to that psych doctor's office and say, hey, I noticed you gave the MMPI and you didn't put the scores in. Can you send those to all parties without writing a supplemental report? Just send them because they should have been in there in the first place. Something to that effect. You want to get your hands on the scores. And if you ever have a question, I'll put this out there. If you ever have a question about what MMPI scores mean, or if there's a problem with them that somebody should be challenging or skeptical about, feel free to reach out to me and I'll take a quick glance at the scores and give you some pointers in which direction to go. But the scores are very telling. When I get my hands on MMPI scores that are where the doctor gave an MMPI, I look for 3 things. I look for the 3 validity scale scores first and foremost of L, F like Frank, and K like kite. Those 3 scores are the top 3 validity scale scores that are very telling of the person's credibility. Credibility is a must to assess in a psychological or psychiatric evaluation. First and foremost, the psych doctor has the opportunity to determine if the person is an honest person or if they're a lying, faking person, right? And psychological tests are the way that psych doctors can achieve that goal of determining the person's credibility. The MMPI is the #1 gold standard test of every psychological test battery, in work comp especially. So the MMPI must be used. Now, when the doctor does not give an MMPI, that is a red flag. The doctor should be questioned about that. Essentially what it means is the psych doctor probably had no way of assessing the person's credibility. To say a different way, the psych doctor was willing to accept everything the applicant told them to be truthful and honest. If they give the MMPI, they're at least taking the step to assess credibility. Now, there are many versions of an MMPI. The most commonly used version is the MMPI-2, and the most recent version is the MMPI-3, published in December of 2020. The doctors can use any of the versions of the MMPI as long as they give an MMPI, right? And then you need to put the scores in the report. And I'll tell you that I also look at the scores, and a score of 65 or higher on an MMPI-2 F, L, or K scale, that means something. So if the score is 65 or higher, the doctor needs to say something about the score. What should they say? Well, according to the psychological literature, all the research on the MMPI, it says that a score of 65 or higher on the L scale means that the person was not being honest and straightforward. 65 or higher on the F as in Frank, the F scale means the person was attempting to simulate their symptoms. A synonym for that is faking or malingering. 65 or higher on the K scale means that the person was attempting to distort their true clinical presentation. Again, faking would be the synonym. So the doctors need to give us those scores so we can determine, because it's rare. Actually, what I usually find in psych reports for the testing section is if the score is 65 or higher on those scales, I read on and I expect the doctor to say something about those scores and the effect that I just described. And instead, I usually read where the doctor says nothing at all about the scores, or they say these scores were elevated and the person was exaggerating or magnifying their symptoms. And then they don't say anything beyond that. They don't say how they took that exaggeration, magnifying, or faking into consideration when they arrived at a generalized anxiety disorder. They don't say anything about it potentially meaning that the person was trying to fake their symptoms in the exam room. So when that happens, there's big problems and the doctor should be questioned about it. The Beck depression inventory, the Beck anxiety inventory, the Epworth sleepiness scale, and a whole list of other psychological tests like the Waller, the Hamilton, the sentence completion test, the list goes on. These tests do not have validity scales. That means there's no basis for using them in a medical legal examination. There's no possible way for the doctor to determine if the person was answering on those tests in an honest or truthful manner or was lying or faking. So if you can't tell if the person is answering truthfully, you shouldn't use the test at all because you can't really take the results of that test at face value. I'll say another thing about the MMPI-2, which is the most commonly used version of the MMPI. That is the testing manual that comes with the MMPI-2. It's about 60 to 80 pages long, the testing manual. It tells the doctor how to give the test, how to score it, how to interpret it, and everything in between. That testing manual says two things that are really important. One is it says the test should never be given at home. The test must always be given under supervised conditions with adequate lighting and ventilation, and under supervised conditions. It says that twice, right? So that's important because on these telehealth exams, how did the doctor give the MMPI-2? Was it supervised? How did they know there was adequate lighting and ventilation? Was it taken at home? These are all big no-nos according to the test manual. And then the second key takeaway from the testing manual is on pages 54 and 55 of the MMPI-2 manual, there's two tables. And the tables say all the possible scores for a male. The other table says all the possible scores for a female. That's important, super important. I can't tell you how many times I've read a psych report from another psych doctor, and it's for a Ms. Smith, right? Where the person marked female and the doctor's saying that it's a female that came to the examination, and all of the scores on the report are only possible for a male to obtain. And there was no mention of transgender issues, nothing of that nature or that effect. And so what's the problem? Well, the only thing that we can identify for certain is the doctor reported impossible scores for the patient to obtain on the #1 gold standard test of their psychological test battery in the work comp evaluation. And the doctor said that there's a generalized anxiety disorder, that it was caused by work, that they had a period of temporary total disability, apportionment is non-existent to non-industrial factors, and there's warranted treatment on an industrial basis for at least a year. So all of these things, but the doctor made a huge error in the #1 gold standard test of their report, and they were paid for the testing. The doctor was paid for the testing that they did. So all of those would be major issues and major problems to deconstruct and also determine the appropriate approach, which I would usually recommend as a general rule, is depose the doctor, ask hard-hitting questions about these major issues, and expose the major problems on the record during deposition. The court reporter's typing away, the doctor's going to be forced to answer to the major problems in their reporting and their methods of the evaluation. I'm going to move on to area number 4 of the psych report. Now, areas number 4 and 5 are actually very not as complex, and they're very simple, so these will be quick. Number 4 area is the review and discussion of the patient's medical records. The doctors get records sent to them by folks like you all the time, right? And the doctor should be first of all, they should be reviewing those records in their report as long as they had the records prior to the exam. A lot of times I see the doctor say, oh, I'll send in a supplemental report with the review of records because they just didn't want to take the time to get to it within the 30-day requirement. And that's a big no-no because the labor code says the doctor has to review every record and piece of information that they had at their disposal at the time of the examination. Second, what are you looking for in this section? You should be looking for two things. One is, did the doctor review any other psych records? Usually you're going to find no other psych records were reviewed. In that case, there's no support in this section for the doctor's diagnosis of a generalized anxiety disorder or major depressive disorder or whatever the disorder is. Number two is, now let's say the doctor did review other mental health or psychological or psychiatric records. What you're looking for is, did those other psych doctors give the same exact diagnosis? When the answer is no, there's no support in area number 4 for the doctor's diagnostic conclusions. That's the gist of that section of the report. And then the final section of a doctor's psych report is collateral sources of information. And I left this for last because, not that it's not as important, but because you rarely find this section of the report or in a report, and that's okay. Collateral sources of information is when the doctor has a need to interview family, friends, or business associates of the applicant. And usually that's not necessary or needed. It's only really necessary if the applicant cannot speak or think for themselves. Perhaps they're a victim of a stroke, they're deceased, they have extreme paranoia where they can't sit or talk and answer questions, which it's very rare. Or they have amnestic disorders where they just, or dementia, so the doctor would need to gather information and collect data from family, friends, and business associates. But because this is rarely needed, it's okay if this section's not in the doctor's report. I'll discuss the GAF score. I mentioned earlier, we have just 2 minutes. The GAF lives in the DSM-4 TR. It was eliminated from the DSM-5 and the DSM-5 TR. If you're ever interested, you can get your hands on a DSM-4 TR and go to page 32, and it gives all the requirements for the GAF scores, the various GAF scores that the doctors will give and how they pick that number to give to the patient. Rounding out our discussion today, these are other CE or MCLE topics that I enjoy discussing. As I mentioned earlier, telehealth is one of those. I need to add it to this list, talking about telehealth psych exams. Questions, if there's any in the chat, I'm happy to answer and respond and continue our discussion. And I appreciate you all attending today. And I hope this information was useful. And if you need any follow-up, I'm available.
Well, we do have one question from Patricia, and she wants to know, can examiners send you a psych report for you to review on the compensability?
Certainly. That's what I enjoy doing. And usually examiners or defense attorneys will email me at this email address here on the screen, the reports in question with the brief cover letter, or if you'd like to hop on a call, we can do that too.
Thank you, Doctor. Your presentation was great. I did have a few comments saying how much they really enjoyed the interactiveness of the QR code and being able to participate in the presentation today. So we always love the technology you bring to us. And we want to thank you very much for our third speaker of the 12 CEUs of Christmas. We have coming up tomorrow a few more. And tomorrow we have structured settlements. Are they still relevant for workers' comp? And then the other one we're going to have is on electronic data recorders, and that's going to be for vehicles. So when a worker is using a company vehicle or their own vehicle, what is that little black box going to tell you? There's a lot of information that they have, whether it is a regular vehicle or heavy equipment. All of our classes will be listed on the MacroPro website, so you can sign up for those. We do appreciate you joining us. And until tomorrow, we want to say thank you and have a good evening. Bye-bye now. And thank you, Doctor.
Thank you.